Good morning everyone. Welcome back to LdL. Today I saw, today I learned. I am Dr. Adarsh Pal and today we are talking about something that walks into almost every doctor's OPD. A patient who just blacked out. Syncope, it sounds simple. Patient falls unconscious, wakes up, comes to you. The cause can range from something completely benign to something that could kill your patient within hours. And as a doctor, it's our job to figure out which one it is fast. So we'll start with a real case and see if you can crack the diagnosis before the reveal. So let's begin the case. A 45-year-old male, Ramesh, he is a teacher and presented to OPD with his wife after a collapse at the bank. So he was standing in a long bank queue on a hot afternoon when he felt dizzy and his vision darkened. There was blurriness of vision and he collapsed. Wife witnessed the fall. He was unconscious for roughly around 30 seconds and after that he woke spontaneously. He was mildly confused just for a few seconds and then he fully recovered. All this happened within a minute. There were no tonic-clonic movements, no tongue bite, no urinary incontinence, no chest pain, no palpitations. So what do you think is the most likely diagnosis? A. Vasovagal syncope, B. Cardiogenic syncope, C. Orthostatic hypotension, or D. Psychogenic pseudosyncope. So the correct answer is vasovagal syncope. Prolonged standing in the heat is a trigger which leads to venous pulling in the legs and reduced cardiac filling. And this activates one of the reflexes known as Bajor-Jewish reflexes, which causes sudden drop in heart rate and BP, which leads to cerebral hypoperfusion and brief transient loss of consciousness. And therefore the classic symptom is dizziness, blurring of vision, blackout of vision, and recovery is complete and rapid, that is within 1 minute. There is absence of convulsive features like tonic-clonic limb movements or prolonged post-atrial confusion. Some amount of conversion can occur. If you see the second option, cardiogenic syncope, cardiogenic syncope usually does not have any prodrome. There is sudden onset without any warning. And it does not need to happen while standing. It can happen even while in supine position also. Case did not have any history of palpitations. There is no history of any structural heart disease and no ECG abnormality here. The third is orthostatic hypotension. So orthostatic hypotension really leads to syncope while there is a positional change trigger, that is from lying or sitting to standing position. Ramesh was already standing for a prolonged time, so changing posture was not a trigger in this case. The fourth is psychogenic pseudosyncope, in which the episodes are prolonged, multiple per day and recurrent. The most important tool in deciphering the cause of syncope is history. So what we have to ask is the first is the trigger. What triggered? Prolonged standing, heat, emotion, pain, during micturition or during coughing or swallowing. And then the loss of consciousness, how long it lasted. That it was brief or it lasted for around 3 to 4 minutes. If it is brief, less than 1 minute, then it is highly likely of syncope. If it is more than 1 minute, then it is not simple syncope. It can be other things like you have to think about the seizures also, focal impaired awareness seizures. Then you have to ask about the prodrome. Was there any nausea, vision darkening, palpitations, sweating before the blackout or before the loss of consciousness? And what was the position of the patient? Was he standing? Was he seated? Was he supine? Or was he exercising? Or was he post-exercise? That all things provide important clues. And then the recovery. Was the recovery rapid and the full, which occurs usually in syncope, like vasovagal syncope? Or the recovery was with there was confusion also, which occurs usually in seizure, or there is cardiac syncope in which the blood supply is hindered for a much longer time. And whether there were any past episodes. So if patient had similar episodes previously also and he had recovered, then it is likely to be more benign if he had recovered without any problems. If the episode has occurred for the first time, then you have to work it up completely. The red flags are if the syncope is occurring during exertion, then it is highly suggestive of any cardiac problem. If the syncope is occurring while supine or recumbent, then it is also suggestive of a cardiac issue. You have to investigate for the cardiac syncope. And if there is no prodrome, there is sudden collapse without any blackout, without any blurring of vision, without any palpitations, then also you have to search for the cardiac cause of syncope. Other clues are family history like sudden cardiac death less than 40 or 45 years of age, and structural heart disease, known channelopathy. This can provide clues. Then the physical examination, the most important thing is to record an orthostatic BP. Orthostatic BP means you will take a baseline BP while supine, and then after 3 to 5 minutes of standing, you will record the BP. The drop, if it is more than 20 by 10 mmHg, then it is called as orthostatic hypotension. And then you can also look for the ECG, in which you will look for the heart rate and the rhythm, respiratory rate, The cardiac murmurs you can auscultate, and if you have to look for any neurological signs, if there are any signs of focal neurological deficit that can suggest a TIA or a stroke. Posterior circulation stroke can mimic as syncope. The key clinical features for identifying vasovagal syncope is there would be a classical prodrome. Either the sweating would be there or dizziness would be there, vision darkening, blackout of vision would be there, and then the patient would usually be standing upright, prolonged standing, and it would be usually a hot, crowded environment, or there can be emotional stress or prolonged standing that can trigger. So these are the important features that suggest that a vasovagal cause of syncope is there. Now let's see a different patient. Suresh is a 62-year-old male, retired engineer. He suddenly collapsed mid-conversation with a colleague in an air-conditioned office. There was no warning, no prodrome, and the loss of consciousness lasted around 2 minutes. Skin was pale. Colleague called the ambulance, and ECG on arrival showed complete AV block with ventricular escape rhythm. The heart rate was 38 beats per minute. He had known hypertensive cardiomyopathy, and he was on amlodipine and bisoprolol. So how is this case different from the vasovagal syncope that we have discussed? First is there was an absent prodrome. It was sudden, unexpected, unannounced. There was no pallor, no dizziness, no feeling of blackout of vision. And it occurs in any position. So cardiogenic syncope can occur in any position, supine, seated, mid-exertion. And exertional syncope is a feature of obstructive pathology like aortic stenosis or hypertrophic cardiomyopathy, or it can occur in arrhythmia, in which the cardiac output is compromised if there is an arrhythmia. Post-event, there can be prolonged confusion, chest pain, and the recovery can be prolonged. And the patient might have a history of structural heart disease or channelopathy. So these are the pointers that you have to ask in every case of syncope. What are the high-risk ECG findings that can suggest cardiogenic cause of syncope? The first is if the complete heart block is there, third-degree AV block is there. Or if it is Mobis type 2 second-degree AV block is there. If the heart rate is very low, that is less than 40 beats per minute. If there are sustained arrhythmias like VT or SVT with rapid ventricular rate that compromise the ejection fraction. If there is a Brugada pattern or the long or short QT interval or WPW syndrome is there. So these are the high-risk ECG findings that you have to look in every patient of syncope. Now this is a different case. Meenakshi is a 72-year-old female. She is a known type 2 diabetic and hypertensive patient on amlodipine 10 mg, telmisartan 80 mg and metformin. So one day she got up from the bed to go to bathroom at 6 a.m. and she collapsed immediately on standing. She felt dizzy for 2 to 3 seconds before the fall. And she recovered quickly when she was lied down. 2 similar previous episodes had occurred, and they both have the history of within 3 to 5 minutes on standing from the supine position. She had peripheral neuropathy on examination. There is no cardiac murmur and normal ECG. So what do you think is different in this case? The key pointers to orthostatic hypotension are syncope occurs within seconds to 3 to 5 minutes of standing from the lying or seated position. And the symptoms improve on lying down. The second clue is that we have to seek is the cause of orthostatic hypotension. So it can be drugs, it can be autonomic dysfunction causing orthostatic hypotension. Like this patient has peripheral neuropathy on examination and type 2 diabetes mellitus. So type 2 diabetes mellitus is a cause of autonomic dysfunction. And she is on multiple antihypertensives, and that can also contribute to orthostatic hypotension. So how do we record the orthostatic hypotension is BP drop. If the BP drop is more than 20 mm Hg systolic on standing, then or 10 mm Hg in diastolic within 3 to 5 minutes, then it is called as orthostatic hypotension. One takeaway from this slide is do not forget to check for the medicines that she is taking. The single most useful differentiator is the prodrome. So vasovagal almost always has a warning, and cardiac syncope has no warning. So you're talking to them and suddenly they are on the floor. And orthostatic usually happens when you are standing up from the sitting position. So the prodrome is the most important thing. And then you look for the clinical clues about each of these causes, like cardiogenic syncope. Is there any history of structural heart disease, cardiomyopathy, or there any ECG signs suggesting a cardiogenic syncope? Then vasovagal, you ask about the triggers. And orthostatic, you ask about the drug history. Is there any cause of an hypotension like autonomic dysfunction, central or peripheral autonomic dysfunction that can cause orthostatic hypotension? So that's how we differentiate between the 3 causes of syncope. So the most worrisome is the cardiogenic syncope. The vasovagal and orthostatic are less severe than the cardiogenic. So how will you investigate a patient with syncope? The first most important thing is you do not need to do every test in every patient of syncope. There are some tests which you need to do in all patients, and then based on history and the preliminary investigations, you need to decide further. So what are the things that we will do in all patients? One is ECG. So ECG is a very low cost tool that can help identify various of arrhythmias or signs of heart disease. And the second is measuring the orthostatic BP along with the history and examination will give a clue to the syncope in about 6 to 70% of the patients. If the ECG findings or there are clues on history that is suggestive of any cardiac dysfunction, then we have to order a echo or if needed Holter. If the patient is suggestive of any orthostatic hypotension and patient has peripheral neuropathy or the patient has like Parkinsonism and we are suspecting autonomic dysfunction, then we can go for autonomic function testing, which includes tilt table testing. So the key takeaways are, first is history is everything. History is important. Actually, it is not just that I'm saying it. The second is in vasovagal syncope, you will have a prodrome in a specific trigger like heat, standing, emotion, micturition, and then we have a brief loss of consciousness followed by rapid full recovery. In cardiac, there would be no prodrome, sudden collapse will be there, and the position can be supine, and that you have to evaluate urgently. And then orthostatic syncope, it happens on standing up from sit position and the symptoms improve on lying down, and you have to review for the medications and you have to review for any cause of autonomic dysfunction. Fifth point is do not over investigate. If you look for history, good examination including orthostatic hypotension and ECG, that will give you clues in almost 70 to 80% of the cases. Treat the cause and not the symptom. So the management of each of these causes would be different. So syncope is just a sign. You have to find the root cause and then treat that. Thank you.